I'm Francesca Crespo. This is for exercise 486, the winter 2017 session. I'm doing my case study on spinal cord disabilities. So let's get started. So what is a spinal cord injury? The spinal cord is just a bundle of nerves enclosed within the vertebral column. Sensory signals are sent through the spinal cord and up to the brain to send a message. When these nerves are damaged, it disrupts the signal that is sent. These two elements, the brain and the spinal cord, make up the central nervous system. The central nervous system is responsible for most functions between the body and the mind. The central nervous system's main job is to coordinate actions to the signals sent from the spinal cord to the brain. If this is damaged, you have a patient with a spinal cord injury. Reasons for this, according to the National Spinal Cord Injury Statistics Center, more than 35% of spinal cord injuries are from motor vehicle accidents alone, so just from car accidents. About 15% is from an act of violence, so such as a gunshot, a knife wound. Other causes can include injuries from falls or sport and recreation. Even diseases such as osteoporosis and inflammation of the spinal cord can cause an injury. So what's the damage? Either traumatic or non-traumatic injury. A traumatic injury would mean that you took a pretty hard blow to the spine in which it fractures, dislocates, compresses a few vertebrae. This can also come from a gunshot wound or an object impaling right through the spinal cord. A non-traumatic injury can come from a nasty infection, cancer, osteoporosis, arthritis, or degeneration of the spine. In both cases, traumatic and non-traumatic, there is damage done to the nerves, which, as we covered before, would disrupt those signals that are sent all the way up to the brain. So with damage like that, a patient could become paralyzed due to the loss of function. Symptoms and diagnosis could include muscle weakness, coordination issues, muscle spasms, overreactive reflexes, and reduced sensations. Medication use can really range from steroids, which will stimulate the hormone effects and to aid with tissue growth and repair, muscle relaxants such as Valium to reduce tension and help with pain, and blood pressure medications to raise blood pressure if it is too low. The effect of a disability on exercise. Every case is different, but there are a number of things that you really want to look out for when getting a patient to exercise. Most importantly, paralysis will seriously limit a patient from specific exercises to the paralyzed area. If you can't move it, you can't really exercise it. Other factors include autonomic dysreflexia, or AD, which can happen to a person with an injury above the 6th thoracic vertebrae. This would cause involuntary actions resulting from your external stimuli, which in this case would be the exercise. It could result in a dangerous spike in blood pressure, heartbeat, and constriction of peripheral blood vessels. Other things to consider are overuse injuries, spasticity, and the medications that are taken by the patient. You have to be really careful if the patient is taking those blood pressure medications that I mentioned before. You really don't want their blood pressure to spike right in the middle of your program because that could give you some problems. So on to my case study. I had a 45-year-old male. His weight is 73 kilograms. His height is 180 centimeters, which would put his BMI at 22 and place him in the healthy category. So that is not a risk factor. His exercise history is that he belonged to a tennis club and played 4 times a week. So he was a very active individual, very athletic. His exercise history, his mother had coronary bypass at 70. This is still not a risk factor just because she was older than 65, even though she did have that procedure done. His fasting blood glucose is a little high. It's 110. That is considered a risk factor because it's above 100. His total cholesterol is 180, not a risk factor because it's below 200. His HDLs are 45, which again is not a risk factor because it's above 40. LDLs are 145, again not a risk factor because it is below 160. He is not a smoker, he has no known metabolic diseases, which would put him in the low risk category. Although the big thing is that he did have a car accident 6 months ago, and he had some damage to the lumbar spine, so he has decreased function in his legs and needs a brace to walk, but he usually rides a manual wheelchair while his therapy is progressing. So, exercise for my client. According to ACSM, my patient should be exercising about 5 days a week. 3 to 5 should be aerobic or endurance-based, and 2 to 3 should be strengthening. Because my client is coming from no activity in the past 6 months, even though he was previously an athlete, we will start his program at 1 day per week and gradually increase the days for a 5-week program. The goals of my client are to increase his upper body to improve his upper body fitness, so strength and endurance for his everyday activities. Activities for him would include moving himself from wheelchair to bed, to toilet, to car, with limited help from others and limited leg function. So he's a very independent person. He doesn't want any help from other people, especially as his therapy is progressing. He just wants to be able to do his everyday activities by himself. So he really wants to increase his upper body strength for that. So for exercise testing, we started by taking his resting values. Resting heart rate was 68. Resting blood pressure was 122/86. For the aerobic exercise testing, we did the arm ergometer. We did a graded exercise test and increased the resistance every 2 minutes. We stopped at 80% of his max heart rate. His max heart rate is 175, so 80% of that would be 140. And if you look at the chart right here, he got up to stage 6, which put his rating of perceived exertion at a 7. We got his heart rate up to 140, so that's where we cut it off. For muscular fitness, he's a very fit person, but since he's only looking to improve on his upper body, that's the only thing that I tested. We did number of pull-ups, bent arm hang, 1 RM bench press. He did 26 reps of pull-ups. He did 1 minute and 12 seconds of bent arm hang, and he did 190 pounds for a 1 RM bench press. So moving on, we did a fitness program week by week for 4 weeks. We started him off at 1 day a week. So week 1, he only did Monday. For aerobic, he did 20 minutes on the arm ergometer. Got him up to rating of perceived exertion to 7 and kept his heart rate between 70 and 80% of his max. For muscular strength, 70 to 90% of his 1 RM. We did 2 sets of 3 reps of bench press, so with a free weight. Muscular endurance, he did 60 to 70% of his max, 3 sets, 15 reps of pull-ups, 3 sets, 30 seconds of bent arm hang, and 3 sets of 8 reps of dips in his wheelchair. So we had him put his hands on the armrests of his wheelchair and just push up. That's a movement that he's going to be using a lot to get out of his wheelchair, so we wanted to strengthen that a lot. Moving on to week 2, we increased it to 2 days a week. We kept his aerobic the same. That's more so of a warm-up. He didn't really want to improve so much on his aerobic. That's really just to warm up his arms, was on the arm ergometer. So same thing, he did 70 to 80% of his max, got up to rating of perceived exertion to 7, 20 minutes on the arm ergometer. Then for muscular strength, he did 70 to 90% of his 1 RM. So he did the same amount of weight for bench press, but we just increased the number of reps by 1. So he did 2 sets of 4 reps. Then muscular endurance, 60 to 70% of his max. He did 2 sets of 15 reps of tricep pull downs, or extensions, whatever you like to call them, on the pin selected pulley machine. So that's just when you pull down. And he did 2 sets of 15 of those, then 2 sets of 15 of bicep curls with dumbbells. And then he did 2 sets of 10 dips in his wheelchair. So we're going to keep that pretty consistent in his workout program because that's a very common movement for him. Week 3, kept it at 2 days a week, so Monday and Wednesday. Aerobic, did the same thing, rating of perceived exertion at 7, heart rate 70 to 80% of his max, and he did 20 minutes on the arm ergometer again. For muscular strength, 70 to 90% of his 1RM. He did 2 sets of 5 reps of his bench press, so same as last time, we're just increasing the number of reps by 1, keeping the number of sets the same. And then for muscular endurance, 60 to 70% of his 1RM. He did 2 sets of 15 reps with bicep curls, 3 sets of 15 reps tricep pull downs. So for this one, we just added an extra set but kept the reps the same. And then 2 sets of 10 reps with skull crushers with the free weights. Then moving on to week 4, we got him in 3 days a week, Monday, Wednesday, and Friday. So this was kind of the goal, to get him to be able to handle 3 days a week. Same thing, arm ergometer, 20 minutes. Then he moved on to muscular strength. He did the bench press with free weights, 2 sets of 6 reps this time. Same weight, just increased the number of reps by 1, same amount of sets. Muscular endurance, he did 2 sets of 15 reps with hammer curls, so with dumbbells, 3 sets of 15 pull-ups, and 2 sets of 8 regular tricep dips. So we had him, instead of doing the dips on his wheelchair, we actually put him on a set of parallel bars to do real tricep dips. So the take-home message for this is that anything is possible. Even with a serious spinal cord disability, one can still accomplish a lot. We see it all the time in the Paralympics, where these athletes are still putting in the hard work and winning against others, and it's really amazing to see. Thank you for watching, and I hope you enjoyed the presentation.